Great. Thanks so much, Catherine, and thanks to the Hepatitis B Foundation for inviting me to discuss hepatitis B across the spectrum today. So I'm just going to pull up my slides here. Then let me switch to the correct presenter view. Let's see, where is it?
Maybe if there's a switch screen, sometimes that pops up if you have double
Yeah,
screens.
there it is. There you go. Perfect.
Perfect.
Well, thanks again. So I'm going to today talk about hepatitis B, and it's going to be a pretty high-level overview because it's sort of challenging to talk about so much of hepatitis B in a short time. But we're going to try to touch upon topics of testing, interpretation of serologies, and then touch a little bit on treatment initiation. Here are my disclosures. So objectives, we're going to first start on a brief overview of the epidemiology of hepatitis B globally, but then focusing here on the US and talk about the cascade of care for hepatitis B, because it's important to really understand the cascade of care from screening, testing, diagnosis, all the way to downstream treatments and sort of the aims of treatment, which is to prevent bad outcomes for patients. We're going to discuss the current approach to testing and vaccination and update everyone on the new guidance recommendations that were updated last year about screening and vaccination in the US. We're going to touch on serologies. That's always a headache for a lot of people. So we're going to try to touch on what are these serologies, how to order them, how to interpret them, and sort of how to use that to place patients in the correct phase of disease of hepatitis B. And then we're going to talk about treatment criteria. There's also some exciting stuff about treatment criteria with WHO guidance coming out in March of this year. And we're going to review that in a little bit of detail. So first, I like to always start with this diagram because it really highlights the complexity of hepatitis B. A lot of times we think, oh, hepatitis B is so simple, right? You test for it, get people treated, and that's it. But really thinking about the entire spectrum, it really starts from identifying those who need to be screened. And luckily now that's been simplified in the US because really everyone should be screened with the triple tests for surface antigen, surface antibody, and core antibody. But even after screening these individuals, that's not the end of the story. When you identify someone with hepatitis B, it's critical to link these individuals into care. And that's an area where there are huge gaps and disparities with timely linkage to care, because it's important to have continued laboratory monitoring for these patients to assess their treatment eligibility, need for liver cancer screening, and then ultimately get them plugged into appropriate antiviral therapy, which is the main aim to reduce, as you see on the end of the spectrum here, reducing these poor outcomes, which include cirrhosis, HCC liver cancer, and of course, liver-related mortality. Oops. This is a figure from a relatively recent, I guess, Lancet paper that looked at the global burden of hepatitis B. And I will come back to this figure a little bit later, but this is first to point out in the first bar, you can see that the global prevalence is almost 300 million. But look at the third bar, the huge gap. In those that have hepatitis B, only a fraction of those individuals are diagnosed. So that highlights the first big gap in hepatitis B cascade of care is timely diagnosis of these patients, because if we cannot diagnose them, we cannot link them into appropriate care and treatment. These are data from the US that we just updated earlier this year. And you can see here that at least in 2022, the estimates for chronic hepatitis B prevalence in the US is about 2 million and as high as 2.5 million. And similar to global prevalence and global epidemiology, there's still a significant proportion of these individuals that have not been diagnosed, and hence the importance of implementing effective screening programs to really identify these people so we can provide appropriate hepatitis B care. These are some of the historical data looking at the evolution of screening recommendations. I'm not going to go into this in detail, but just to say that with time, our approach to hepatitis B has evolved. You can see in the past, it was primarily risk-based, which, as you can imagine, introduces a lot of stigma. To say someone is high risk for an infectious disease, I mean, that puts a lot of stigma on these individuals. So I'm very glad to see that with the advocacy of many groups, including Hepatitis B Foundation, the CDC has updated the recommendations as of March of last year, and it is now recommended that hepatitis B screening should be performed in all adults with the triple panel, as you can see here: surface antigen, surface antibody, and core antibody. And we hope that this will really simplify, reduce stigma, and ultimately improve early diagnosis of individuals with hepatitis B so that they can be linked to care and treatment in an effective manner. Now we're going to jump into what are these serological markers. So this can be confusing and a headache for a lot of people. So I'm going to briefly review what are these serological markers, what do they mean, and how do we interpret them? So these are really the 5 main markers, I guess you would say, for hepatitis B. The ones on the left are the ones that have been recommended for screening. Surface antigen, you can see here, is a marker of infection. So persistence of surface antigen for 6 months or more is really a definition of chronic hepatitis B. Surface antibody, or anti-HBs, is a marker of immunity. So whether it's vaccination or self-clearance, people that develop surface antibody are, in a sense, immune from hepatitis B infection. There's some caveats to that, but in a general sense, I think that's accurate. Core antibody, I like to think of as a marker of exposure. If you're ever exposed to hepatitis B, whether it's cleared or not cleared, your core antibody will be positive. So the flip side of thinking about that is if you're vaccinated only, your core antibody should not be positive because your immunity is through vaccination and not through infection. Once someone has hepatitis B, then we look at some of these other markers on the right, their viral level and their e-antigen status. And that's important for categorizing them into the correct phase and then for assessing their treatment eligibility. These are 2 figures that I will just briefly mention, and it helps to picture the changes of these serological markers over time in 2 scenarios. So the top scenario is someone that was infected and then self-cleared or recovered. And you can see here the hallmark is the red line. The surface antigen spikes and declines as the body's immune system clears it. And then the marker of recovery is the persistence of anti-HBs or surface antibody. And you can tell here that both the core antibody on top and the surface antibody on bottom indicates that this person has been exposed and now has cleared the virus and is immune. That's distinguished from the bottom figure, which shows chronic infection. And the hallmark here is the persistence of surface antigen. You can see the similarity that both of these individuals have core antibody, which makes sense because both have been exposed to the virus. But the key difference here is for chronic infection, you have persistence of surface antigen and lack of surface antibody. These are just in words, for those for your reference, for those that want to go back to this to really describe what these different markers mean. So I'm not going to read this in too much detail because it's really just what I explained in some of the previous slides. So this is a quiz. Usually in person, I quiz people on this, but as a large group, it's a little bit tricky. But just think to yourself, I'm not going to ask anyone, point anyone in particular, but think about these different scenarios and try to guess before I show you the answer. The first patient has no surface antigen, has positive surface antibody, and no core antibody. So they've never been exposed, they don't have active infection, and they have immunity. That means they've been vaccinated. The second scenario is somewhat similar. The only difference here is the core is positive. So remember, core means exposure. So this is someone that was exposed, but now has cleared and recovered, and in that sense is immune because of the persistence of surface antibody. The third one's easy. All are negative, so never exposed, never vaccinated. This person needs vaccination. Third one, chronic infection. Persistence of surface antigen, no surface antibody. And again, the core being positive shows exposure. The last one is a little bit tricky. I didn't really put an answer there. This happens not infrequently where you have an isolated core antibody. It can be due to a variety of reasons. First, you want to make sure this is not someone that has low-level chronic infection. So you want to make sure you rule out a detectable viral load. So check their hepatitis B viral load. Other potential is these, in the same sense, could be precore mutants. So they may have negative surface antigen, but still have detectable virus. And that's why it's so important to check for the viral load. And then finally, these could be people that have low immune response despite having a recovered infection. So while they may have been exposed and cleared it, their qualitative surface antibody does not trigger a positive result on the assay. So once someone has chronic infection, it gets a little bit more complicated. So this is just to highlight the different phases of hepatitis B. And as I mentioned in the past, it's based on the e antigen status and the viral load, and then whether the ALT is elevated or not. Patients can shift from one phase to another, and you can see here the distinguishing features are based on the immune reaction, and that's illustrated by the inflammatory elevation of ALT, whether the viral load is elevated or not, and then the e antigen status you can see here does distinguish between the different stages on top. So I'm not going to go into too much detail with this due to time, but just to show you the way we categorize the different phases of hepatitis B based on these serologies. Testing is important, but there are big gaps. These are 3 studies that I just want to highlight across different populations that show time and time again, testing for hepatitis B remains very suboptimal. Even though we're recommending everyone to be tested, these are now older studies in high-risk individuals, even in populations where we previously recommended specific testing, the rates were very low as 18.6% in some studies. Why is that? Well, part of it's due to education, and programs like this today really help improve those gaps. These are data from the NHANES, which is a US-based survey study of adults, and you can see here some alarming observations. Among those with hepatitis B, less than a third were aware of their infection, and of those that were aware, only 28% reported being treated for hepatitis B. Alarmingly, we found that there were factors, especially socioeconomic factors, low education level, that were associated with less awareness for hepatitis B. This is important because that translates into linkage to care. This is one study from a safety net hospital that showed low rates of linkage. Even among a GI clinic cohort evaluation, we saw that less than 60 or 63% of hepatitis B patients were adequately linked to care. Of course, we saw that those with a primary care provider were more likely to be linked. We also saw some ethnic disparities, which are important to think about in whom to target in terms of outreach and engagement to care. Linkage is important, but follow-up is also important. This study also looked at retention, which is continued monitoring beyond the first visit. And you can see here less than 70%, or the flip way of saying it is about a third of patients were lost to follow-up beyond the first visit. And that's concerning because loss of follow-up means no monitoring, no testing, no treatments, and then hence continued disease progression. And this is a follow-up study from the same cohort that showed over 28 or 27% of hepatitis B patients in this safety net system already had cirrhosis at presentation. Many of them also had signs and symptoms of decompensated disease. And this is very alarming because this is potentially preventable. If you catch patients early, implement treatment effectively, you can prevent disease progression to cirrhosis and liver cancer. And this is just to highlight those complications that we try to prevent: cirrhosis, decompensation, and liver cancer. And it is preventable with effective viral suppression with current antiviral therapy. What is the 5-year risk of progression? Studies show that risk of progression is up to 20%. We know that high viral load and the duration of infection are key factors that influence disease progression. But it's also important to think about concurrent risk. Alcohol use is unfortunately increasing, especially during and post-pandemic, and that can have synergy with the virus and lead to more progressive liver damage. And they're not going to talk about concurrent viruses, but also think about effective screening for Hep C, HIV, as well as Delta virus in your patients with hepatitis B. Decompensation, risk of further progression once someone's developed cirrhosis to decompensated is about 20% at 5 years. Once they develop decompensation, this is really unfortunately a downward spiral because you can see here 1-year survivals only as low as 50% in some patients. And that's why the goal is to identify these patients early to prevent even getting to these steps by effective linkage to care. HCC, I'm just going to briefly touch on this because I know you will have a session next month. But HCC is one of the feared complications of hepatitis B. Annual risk is about 2.5%. But it's also important to realize that as high as a third of patients with Hep B-related HCC don't have cirrhosis. So I'm not going to talk too much about screening because I think Dr. Roberts will talk about that. But liver cancer screening is also an important part of hepatitis B care in addition to assessing for antiviral therapy. This is just a figure to kind of summarize what I talked about in terms of the disease progression, risk of progression in terms of cirrhosis and HCC, and ultimately the goal of chronic hepatitis B management is to catch them early to prevent these downstream complications. This is just one slide I want to briefly mention that really emphasizes the importance of timely antiviral therapy. There are many, many studies. This is just one hallmark study that I pulled out that show the clear relationship between viral load and risk of disease progression. The higher the viral load, the higher the risk of cirrhosis and HCC, and hence suppressing viral replication with antiviral therapy would then lead to reduced risk of these complications. Now we're going to move and finish up with treatments. It's treatment, as many of us know, has been very complicated. There is a trend towards simplifying this, which I will mention, which is very reassuring. There are a lot of guidelines. I'll try to summarize them in a slide. And then I want to touch on the recent WHO recommendations that came out in March of this year. A plug is that the AASLD is in the process of updating their hepatitis B guidance, and we're excited to see that come out hopefully very soon. In patients not on treatment, generally AASLD recommends this monitoring labs, e-antigen, to assess for treatment eligibility based on the parameters that we're going to see on the next slide. So you can see here it's a bit complicated. I put up the 3 major society guidelines: AASLD, APASL, which is Asian Pacific Association, and EASL. And you can see how complicated it is. It's a combination of liver enzyme ALT, viral loads, maybe stage of disease if someone has had biopsy or non-invasive testing, and e-antigen status. In 2023, there was proposed a simplified criteria, which you can see here. Really simplifies it in the sense that based on one cutoff of viral load greater than 2,000, and whether your ALT is greater than upper limit of normal, the guideline or the guidance document recommends implementing antiviral therapy. So definitely moving in the direction of simplifying this for people to easily and I think more effectively initiate antiviral therapy. As I mentioned, WHO came out with their guidance of March of this year, which really, again, tries to simplify this. Not going to read this to you in detail because you can see it yourself. But really, you can see, especially on the second line, aligns very well with the simplified criteria that anyone with high viral load, threshold of simple 2,000, and elevated ALT is recommended for treatment. I think this really moves the needle forward to simplify and expand criteria, especially since we have highly effective, safe, and relatively accessible therapy that's currently available. And more we see there's clear data about the benefits of early initiation of antiviral therapy. What are the treatment options available? Interferon is available. It's rarely used. Most of us use the oral antivirals. There's 3 available. All are once, for the most part, once daily dosing, easy to take. And there's some pros and cons between the different treatments, but there's not time to go over that. But in general, all of these are relatively similarly effective. Back to this graph that I mentioned, in addition to looking at gaps in diagnosis, there are gaps in treatment. You can see in the second bar the estimate of treatment-eligible patients globally, and then the last bar are those that are actually on treatment. So huge gaps in effective linking to antiviral therapy. We see this in the US as well. This is a paper published last year for safety net hospitals in the US of over 5,000 individuals with chronic hepatitis B using ASLD criteria. Of those that were eligible for treatment, less than half, you can see here, 48% were actually started on antiviral therapy. We saw some gaps and disparities with lower treatment in women compared to men, and some differences by insurance status as well as ethnicity. So definitely gaps and disparities here that deserve more attention in research to address those disparities. What are implications? I think we know this from some of the previous slides I mentioned. Delays in treatment lead to continued disease progression and allows the virus to lead to progressive liver damage, cirrhosis, and liver cancer. What are the data that emphasize this? There are several data, but I just highlighted one here. You can see this is a multi-center real-world study of patients treated versus not treated. And you can see in the figures, the dotted line represents those that were not treated. The solid line represents those that were treated, and the outcome is liver cancer. So overall, and whether you look at patients with cirrhosis or without cirrhosis, it's pretty clear that antiviral therapy does reduce the risk of liver cancer. So then I would just end with this. We talked a lot about screening, linkage, treatments. It's also important to emphasize vaccination. So if you screen someone that doesn't have hepatitis B but is not immune, they should be considered for vaccination. And this is an updated guidance from the Advisory Committee on Immunization Practices a couple years ago now that recommends implementing universal vaccination in adults, basically. So with that, I will end. The cascade of viral hepatitis care is very complex. We showed on the first slide the spectrum from screening, diagnosis, linkage to care, and access to treatments. And it's really a lot of different factors at play. There's patient factors, provider factors, health system, access, and there are also other players that can help influence and improve some of these gaps. Payers, advocacy groups, societies, public health, and the solution, there's no one solution for this, but any solution, I think, in my mind, has to incorporate all of these multifactorial groups and factors to really develop a individualized intervention to improve the care that we provide for patients with hepatitis B. So with that, take-home points, hopefully I've emphasized major gaps that currently still exist and persist, which lead to poor patient outcomes. And we really need effective implementation of these new universal screening guidelines as well as vaccination. And we must also not stop there. You have to ensure, even beyond diagnosis, timely linkage to care and treatments. And really the goal is to screen, vaccinate, link to care, and ultimately get these patients plugged into treatments. Thank you.
Thank you so much. That was a wonderful presentation and a great overview of hepatitis B and care delivery and areas where we can certainly work towards improvement too. I'd like to invite anybody who may have questions to either put them in the chat box or to raise your hand at this time. I do have a couple of questions maybe, if you don't mind. I appreciated the emphasis on the need to work towards linkage to care. I know one of the previous studies that you highlighted noted 1/3 of patients are lost to follow-up. I know in Philadelphia, we have a really high rate of loss to follow-up as well. I was wondering if you have any strategies that you've used or you've seen to be effective at really trying to make sure that folks come back after testing positive for hepatitis B.
Yeah, thanks for that question. It's definitely a major concern because there's a lot of, unfortunately, a lot of hepatitis B patients out there floating around, so to speak, that are not getting appropriate monitoring. And I think there's a lot of different reasons and also a lot of different strategies that could be implemented. Depending on your health system, some systems have sort of these dashboards or these ways where they can pull labs, identify lists of patients with positive surface antigen, for example. And if you have adequate resources like patient navigators can sort of reach out and try to re-engage these individuals. Second, education is important. Some of these individuals um, may not understand the severity of hepatitis B. We did, back when I was at Highland, we did these surveys of patients to really try to understand their knowledge gaps and perception of hepatitis B. And some of them, part of it, I think, is our fault too. Some of them came back and said, well, they told me it wasn't serious, or they told me, it was immune tolerant, or it was inactive, so this perception that it's not something you have to worry about. So we really have to also change that dialogue and change the way we think about it's infectious disease. We shouldn't really be calling it inactive. And we really should try to emphasize the importance of close monitoring for these patients.
Yeah, thank you. I appreciate that too, because I think that inactive makes people think, oh, I don't have to do anything now. I just, see
Yeah.
what happens kind of, which I think, kind of reduces the urgency or the need for folks to feel that they need to follow up. And in that same line, I wonder how you might suggest like communication to people about liver cancer screening and what that might look like for somebody with hepatitis B long term.
Yeah, that's also an interesting point because, a lot of the other aspect too is a lot of these patients feel perfectly fine. So they're asymptomatic, and so they sometimes feel, why do I need to be getting testing so often? Why do I need therapy? Why do I need to get ultrasound every 6 months? And and depending on your patient, some of these tests actually are associated with out-of-pocket costs. So it's not, it's not easy for patients. And I think thinking of this multifactorial ways to address, I think costs are very important, especially for some of our socially disadvantaged patients. You know, even $50 a month, I mean, that's a lot of money if you're trying to struggle to put food on the table, working two jobs, etc. So I think really addressing this in a very comprehensive manner is important. The other factor that I think is important, which I know, Catherine, you do a lot of work on this too, is the stigma. So we've this whole concept of hepatitis B, sure, it's an infectious disease, and the way we've approached it in the past is you're high risk. You know, you're at risk, you need treatment. You're at risk, you need cancer screening. So it's very stigmatizing. And I also, you're the expert in this, but I also have always wondered, to what degree that kind of residual stigma, especially in ethnic minority or cultures where that kind of stigma can be very impactful, is preventing them from seeking care.
Yeah, definitely. I think it can be kind of paralyzing for a lot of people. And it's definitely a real thing, and something that we're continuing to explore. And I think different contexts, it's different what people experience as well. But a really good point to think about as well. I see Dr. Rutland, you put in a question in the chat. Did you want to ask the question that you have?
Sure. Thank you, Dr. Wong, for this presentation. I couldn't have said it better as far as the stigma and as far as the cost and the communication. Many of my patients who are forwarded to me by my colleagues because they have chronic hepatitis B will tell me, oh, I was told about it years ago, but I feel fine. And
Mm-hmm.
they have no idea that they need to be monitored pretty regularly and that, you know, the virus can go left at any given time because we just don't understand enough of it to understand what will trigger that. But my question was, there have been updates in treatment, which I'm so happy that they've made it more simple.
Mm-hmm.
Has there been any updates on when to stop treatment once you've started it?
Yeah, that's an excellent question. Treatment, unfortunately, at the moment is still long term, because the goals of treatment are cure. Unfortunately, with the treatments we have now, it's very different than hepatitis C, where 95% can completely clear the virus. Hepatitis B is unfortunately very unique. It's a DNA virus, it's integrated. And the closest we can get to cure is something called functional cure, which is turning the surface antigen to become negative, having undetectable virus, and then hopefully normalizing the ALT. Unfortunately, that's it's not very common. With the current antivirals, it's 0.8 to maybe 1.2% per year. So even someone that's been on this for 30 years, it's the minority of patients that can achieve this. But we don't have them now, but you mentioned new therapies. We have a lot of exciting therapies on the horizon, not quite ready for use, but hopefully, maybe in the next 5+ years, we hopefully have something to add to our armamentarium for hepatitis B that can really lead to finite treatment. Unfortunately, for now, once I start someone on therapy, I tell them that for the most part, it's lifelong therapy.
Thank you.
Thank you.
And Dr. Chanta, I see you have a question. Did you want to ask that, or would you like me to read it off for you?
One question about before positive when we screening with hepatitis first. Do we need to give the vaccination to this patient hepatitis B series, complete series? Because some patients the not less the paper, the evidence base, some evidence that they respond not well for the vaccine. I don't know about the recommendation for this patient.
Yeah, that's a great question. So I saw the question here. So the question is, for patients with isolated anti-core, what is the approach to vaccination? So it's very controversial. I think if you ask 10 people, you might get 3 answers. But the first thing I always ask is if I have a patient with isolated core, I try to ask them or review their record to see if they've ever received the vaccination. Because if they have not, then these are people that, well, then they probably, they've been exposed to hepatitis B based on the core, because the core is um, it's a pretty sensitive test, so it's very unlikely to be having a false positive. So they probably have low levels of surface antibody. So for these patients, I do give a booster. It's not clear if that makes a huge difference in these patients. It probably doesn't hurt. But the data are very conflicting about whether there is a need to continue to boost these patients to get a surface antibody response, or whether you just can continue to monitor them. I err on the side of taking a more conservative approach and give a booster to these individuals.
Thank you. That's great. Great. Well, I think we can move on to our case discussion at this time. Dr.